Turarula, I think we can start now.
Yes, hello.
Yeah, go ahead, please. We're recording.
Okay, Assalamu alaikum. Good evening, everybody. Join me to welcome Dr. Osama, who's going to be our speaker for today. Dr. Osama is working at Al Qasimi Women and Children Hospital as a consultant OB-GYN with a special interest in the minimal invasive surgery and reproductive medicine. Thank you, Dr. Osama, for the lectures, and he's also a lecturer in a university and a good speaker in many conferences. Today, he's going to talk about the topic of preconceptional care. Please, Dr. Osama, the microphone is yours.
Good day for everyone. Thanks, Dr. Yahya and Dr. Aurora, for inviting me to this teaching session. As regard my background as an obstetrician and gynecology, I thought that's going to be a talk today about some topic which will interest the pediatrician, neonatologist, GP, as well as obstetrician and gynecology. And I found the title of preconceptional care is considered one of the not recognized a lot by our specialty as well as GP, family medicine, and pediatrician. So we'll try to throw some highlight about the role of preconceptional care and its benefit in our practice. So it was found in USA that half of the all pregnancy were unplanned. This was in 2015. It was realized that by the time women knew that they are pregnant, at least 1 or 2 weeks has gone from her pregnancy. So when we see her, she already pregnant for maybe a few weeks. So we thought as a physician to find a strategy that mitigate potential pregnancy risk before conception. So CDC in 2015 has made a set of intervention that aim to identify, modify, and biomedical, behavioral, and social risk to women's health or pregnancy outcome through prevention and management. Through prevention and management. This is the most important words in the title. Before we start, we just need to clarify a few definition. There is preconceptional, there is periconceptional, and interconceptional. Preconception is the health status and risk before pregnancy. And this focus extends to partner men as well. It's not only for women. About periconception is immediately before conception and through the few weeks after conception where the organogenesis happens. Interconception is a period between pregnancy. So we have to differentiate between all these topics together. We come to the question, is it really important to learn about preconceptional care? Of course, improving the mother preconceptional health result in improved reproductive health outcome. Whatever you prepare before pregnancy, you will gain with the pregnancy and the pregnancy outcome. It was found to reduce the maternal morbidity and mortality. Also prevent low birth weight, premature birth, and infant mortality, which is a topic of interest to pediatrician and neonatologists. In a statistical study to compare infant mortality rate in 2017 in different countries all over the world, Monaco was ranked the best country all over the world with infant mortality only 1 in 1,000. When we go down through the country, United Kingdom comes in the ranking 22nd, United States 28th with 5.9, UAE is 10 per 1,000 births in the ranking of 88, Egypt 19 per 1,000 births, infant mortality in a rank of 141, and the worst country is Afghanistan with 110 per 1,000 births with infant mortality. So what is the goal of preconceptional care? As we mentioned from the previous statistics, we need to improve the outcome. So we have to do some steps through screening of high-risk factor, taking a full personal history, medical and surgical history, and of course, the previous obstetric history of the patient. Family history is also important, in addition to the usual physical examination and some blood tests to do laboratory screening. So over time, we have realized that preconception health promotion provide a pathway to primary prevention of many poor pregnancy outcomes. Beyond that, available through traditional prenatal care. If you wait till the patient becomes pregnant and you do the antenatal care, it may be too late to do a primary prevention. The primary prevention always happens before pregnancy occurs. In obstetrics, many of our outcomes of their determinants are present before we ever meet our patient. So a patient may have this problem, no one knows about it, and the patient herself is not aware about carrying a risk factor, and she got pregnant, most probably unplanned, and then come to us, landed in our antenatal care, asking us to sort out or what is discovered. So the preconceptional care is a critical period for the prevention of poor pregnancy outcome. And already this time has been already passed by the first prenatal visit. So it will be very limited options to offer to the pregnant lady to help her to improve her outcome. Okay, so next question, who, when, and how? Who will provide the preconceptional care and when to do it and how to make a setting, clinical setting for that? Who, as I said, it is a time which can be covered by either gynecologist, pediatrician, neonatologist, internist, family practitioner, GPs. All these physicians can participate in providing preconceptional care. Because patient can come to gynecologist for a reason or another, come to a pediatrician with her baby, previous baby, coming to medical specialist with some medical problem, or even with GP or family practitioner, and it is good time to start the preconceptional care. So definitely the one who provides the preconception care should have the knowledge, skills, otherwise to refer to the best person to talk about it. When to do this preconceptional care? Any visit to doctor in the reproductive years, you can start and initiate the discussion about the preconceptional care. During annual health checkup coming for a smear test or for managing any medical condition, it is very good time. Postpartum checkup, it is excellent time with the patient keen to see her doctor after she had her baby, and then you can initiate the discussion. Any visit for a pregnancy test, especially if it is negative, before positive pregnancy test is a good time to start the preconceptional care. If she come to ER for emergency visit or coming for infertility or subfertility advice or management, it's a good time as well. And premarital counseling nowadays is the best time to discuss few issues about future pregnancy. How can we do this preconceptional care in a clinical setting? So the clinical setting aiming to give protection, managing current condition, and discussion about the exposure to teratogenic or otherwise harmful drugs or medication. So this is the aim of the clinical setting to be arranged for discussion of the three main topics. Giving protection. So how to do protection in the preconceptional care? Example, folic acid is very common. Patient to receive folic supplementation during her first 3 months of pregnancy. But the one we need to give prior conception to improve her storage of folic acid, to get pregnant while her folic acid is already in her system, rather than wait till she get a positive pregnancy test and few weeks passed where the neural tube close quite couple of weeks after conception. So it's better to have the folic acid if she's planning for pregnancy. Also, immunization is better the woman to get pregnant while she already have the protection from viral, bacterial disease or whatever which can harm her baby. Example of these are rubella vaccination, or at least checking her immunity for rubella, varicella immunity or varicella vaccination, and hepatitis B. These 3 immunization vaccine cannot be given during pregnancy. That's why it's better to be offered during preconceptional care. Primary prevention opportunity to prevent congenital anomaly include giving folic acid to prevent neural tube defect, and this can be prevented by simple tablet, very cheap tablet available everywhere, and this can help preventing a major problem on the baby. So it's 50-70% can be prevented by a simple tablet taking. Birth defect like sacral agenesis, cardiac defect, and neural tube defect also can be reduced significantly from 10% to 2 to 3% through just a glycemic control of the women before she got pregnant. So if someone knows she's diabetic, either type 1, type 2, or pre-diabetic, we can check her before planned pregnancy, control her blood sugar, strict control of blood sugar. This will significantly reduce her risk on the baby. Also, minimize prospective mother contact with teratogenic exposure, like medication, environmental exposure. You have to explain to the patient this material, this medication, this environmental exposure can be hazardous to her baby. So it's better to avoid or to stop using any substance which can affect her baby in the future. Also, one of the preconceptional jobs you do have to do is parental karyotyping if it is necessary, especially if the family history carrying any abnormal baby before. Screening for sickle cell disease, thalassemia, especially from the Mediterranean area, because parent could be both carrier and there is a good chance the baby to have a disease. So it's better to screen and simple tests as well. Dietary advice for women with phenylketonuria, it's just simple dietary advice prevent a lot of damage to the baby if she got pregnant while she's not on a special dietary management. We have to take note of maternal age as well. As we all know, women at both ends of reproductive age spectrum have unique outcome to be considered. So the ideal age of pregnancy actually is between 20 and 35. If you go to the extreme end, like teenage pregnancy between 15 and 19, it is usually unplanned pregnancy. Young girls most of the time suffer from anemia, malnutrition, and they are at high risk of preterm labor, preeclampsia, and sexual transmitted disease. These all need to be corrected and treated like anemia and sexual transmitted disease before she got pregnant. Women above 35 years of old, of course, the more age, the more risk on the mother and the baby. On the mother, it was found that more maternal mortality happened above the age of 35. Women above 35 have a risk of developing diabetes, preterm delivery, hypertension disease, and some women, if they have delayed their pregnancy, they may went for assisted reproductive technology, either for subfertility or they delaying their family till they complete their career. So we have to consider the assisted conception is one of the risk factors in women above 35. Babies for older women suffer usually from IGR, intrauterine growth restriction, preterm labor, aneuploidy, especially trisomy. And as we all know that multiple gestation and multiple pregnancy is common in elderly women, especially with multipara. If we reach to discover some medical condition in the mother, so we need to do some managing this condition before conception. Please don't wait till she becomes pregnant and then start the management. Like chronic disease, if the patient taking medication or she had some sort of addiction. So condition need to be managed in preconceptional period, known to be very detrimental to reproductive outcome. If it happen like uncontrolled diabetes, maternal phenylketonuria, obesity with high BMI, hypothyroidism, and sexual transmitted infection. So all these need to be screened. If anything discovered, need to be managed properly in preconception time. I will give some example for women taking anti-epileptic drugs because epilepsy, and she has this long term. We trying to reduce the number of medications she takes for her treatment. If she's on multi-regimen dose and she's planning to get pregnant, in her preconceptional counseling, she should reduce the number of medication to maybe 1 and try to choose the less teratogenic one. And the teratogenicity calculated by relative risk factor. And it was found that lamotrigine is the lowest drug which cause fetal anomalies and teratogenicity. So its relative risk is 1.8. So this is the only medication we prefer now during pregnancy. So patient better to start on this in preconception and to continue. Aiming to prevent any seizure before conception and maintaining her level of medication in the blood to the lowest, this definitely improves the maternal and the fetal outcome. Patient with diabetes, we aiming in the preconception time is to achieve a strict glycemic control, as we said before. And the best is to check hemoglobin A1C, and it's better to be less than 7. If a patient with high blood pressure and she's taking medication not preferable during pregnancy, like AC inhibitor, angiotensin converting enzyme inhibitor, or angiotensin receptor blocker, these need to be stopped and changed to another medication which is safe to continue if she fell pregnancy in a few weeks' time. Any chronic hypertension, you need to assess the renal function, cardiac function, and retinopathy, aiming to improve her condition before pregnancy. If a patient on a replacement therapy for hypothyroidism, taking thyroxine, we have to check her thyroid function. And in our obstetric practice, we prefer women to get pregnant while her TSH not more than 2.5 milliunit per liter. If it is more, you have to increase the supplement a little bit to make this TSH less than 2.5. I know the non-pregnant state level can go to up to 5, but in pregnancy, to be healthy, it's better to be below 2.5. If patients have hyperthyroidism and taking medication we don't prefer in pregnancy, like propylthyroxine, you have to change it to carpimazole, and aiming to keep the TSH in the low normal level and the thyroxine T4 at high normal. So this is adjustment. It may take few weeks before reaches the required level. So this needs time, and this is a good time in the preconceptional care. Patient with systemic lupus, we need 6 months at least of no activities before she got pregnant. Patient with cardiac illness, this is a big dilemma. Some women have cardiac disease, either diagnosed or undiagnosed, so it's better to be checked in the preconceptional time. Mild cardiac disease, easy to manage, but the problem there is women who have developed a cardiac disease or cardiac condition which is not suitable for women to have to be pregnant while have this condition. Cardiomyopathy, restrictive pulmonary fibrosis, this need to be advised that is quite risky for the mother if she got pregnant. Some women come to us pregnant few weeks, 8 to 10 weeks, and said we have this issue. So we have to go through the dilemma of counseling for termination of pregnancy for the sake of the mother life. So it's better to avoid all this by counseling the patient, give advice, preventing this to happen. If the patient needs a surgical correction for her cardiac disease, it's better to be done as well prior pregnancy, so she can accommodate pregnancy and maintain her maternal adaptation in a good way. Patient taking anticoagulant for a reason or another, and usually we give warfarin or the new drug Duac, is not good for women who's trying to conceive. They have detrimental effect on the baby, so it's better to shift to unfractionated heparin or low molecular weight heparin. Of course, any women with cardiac disease, there is a small risk that he can be transferred to the baby. So the patient needs to know if she can accept this risk or to avoid pregnancy. And also in cancer patient, they may need to go for chemotherapy, and they would like to have to complete her family later on. There is an option nowadays, which is called fertility preservation, either by taking the egg from the ovary or part of the ovarian cortex and freeze it. Then if the chemotherapy has damaged the ovary during the treatment cycle, she has the option to use it later on after she had the cure. So these also need to be discussed clearly. What about avoiding exposure? So exposure means if the woman is exposed herself to atteratogenic drugs or harmful material, she needs to give up and to give away from this exposure if she's planning to be pregnant soon. Like as we said, the anti-epilepsy medication or oral anticoagulant or patient using acutinate for acne treatment is not safe during pregnancy. It's better to stop and replace it by something else. Always we advise stop smoking and alcohol if she's planning to start her family or to continue with a pregnancy soon. So it's better to give up from this alcohol and tobacco. If we talk about drugs, so FDA classification of the drug in pregnancy in 1997 classified drugs from A to X. A, B, C, D, E, X. And this A is the most safest drug to be used in pregnancy. X is completely forbidden and contraindication to be given in drugs. However, in 2015, this classification has changed and is not of use anymore. So we can't find any drugs now called category A or B or C, but it will be different categorization. So the new rule of FDA of drug categorization started from end of June 2015, says the final rule requires that labeling include summary of the risk of using drug during pregnancy, lactation, and by female and male reproductive potential. So the drug need to mention what is the risk on the pregnancy, on lactation, or even on the female in the reproductive potential, male or female in reproductive potential, even if she's not pregnant currently. So all these need to mention. And the mention based on several randomized studies about the effect of this medication. So we leave it for the healthcare professional to decide if this medication is safe to give or not. Based on, you weigh the benefit and the risk. If it is very high risk, advise not. If it is moderate risk and the benefit you think is gaining well to the mother, so you can prescribe. So this is, you have to do extra effort to read about this medication and its effect before prescribing to the woman. So the responsibility now moved from the FDA classification to the healthcare professional to decide to give or not. And this is a new labeling one on the right side. So in each drug label now, you have to have risk of pregnancy, including labor and delivery, risk on nursing mothers during lactation, and even you have to mention if this medication is safe to give to young girls or young men, even before they go to family planning or being to have children or to have a family, maybe this medication have some potential adverse effects on their fertility in the future. So how to achieve this preconception wellness? They found there are 3 tier levels of preconception wellness. The challenges actually happen when the general awareness of the population routine health check, promotion, and specialty care. This is the 3-tier. We need to look at it to see if we can achieve achieve our goals through preconceptional care. They are intertwined, interdependent, and all three necessary to move the agenda forward successfully and systemically. So general awareness, routine health promotion, and specialty care. Let's take one by one and see what is that. Actually, general awareness is a very big challenge. People in the general population may not aware about the importance of the preconceptional care and its advantage on their future pregnancy. So this need to be addressed well and be promoted through our job as a professionals, healthcare professional, either gynecologists, pediatrician, family doctor, and GPs. We need to make people more aware about the importance of this preconceptional care. Women most in need of preconceptional health promotion are those least likely to have intended conception. This is the issue. Most of the women who got pregnant unplanned, this is the women we need to give them the preconceptional care. Because planned pregnancy, maybe a patient planning after 6 months, they have a chance to go to her doctor, discuss, and she might receive. But the problem is with the unplanned pregnancy, they don't have any time to do this preconception care. So general awareness is very important. And we should take any opportunistic care during women visit to us. So every woman, every time is opportunistic care. So please take the advantage of all healthcare encounter to stress prevention opportunity through the lifespan. Recognize that almost all cases, preconceptional wellness result in a good health, not only for the mother, but also for the fetal outcome. Addresses the conception and contraception choice at every encounter, involve all medical specialty, not only the directly involved in reproductive health. So whatever the woman come to you for a reason, as she's planning for pregnancy in the near future, or for another reason, you have to take this opportunity to discuss the preconceptional care. So what we need actually to strengthen the health promotion and disease prevention initiatives for all women, irrespective of their reproductive plan, either she's planning soon or she's not planning, because many cases not planning and fell pregnant as an unplanned pregnancy. So remember this one, every woman, every time. Any woman come to you to encounter you in any clinical setting or any practice, it's a good time to discuss the preconceptional care, because women's health in and of itself is important. So how does the clinician fit preconceptional health promotion into encounter? If you take care of women of reproductive potential, in a reproductive age between 18 and 45, it is not the question of whether you provide preconception care, it is the question of what kind of preconception care you are providing. We don't need quantity, we need a quality of care. So the quality of care comes after you have the knowledge, experience, discussion, and this will give a very good quality of preconceptional care to women. To sum up, any preconceptional health will lead to a very good, healthy, pregnant woman, and eventually it will end to a healthy families. Thank you very much for listening.
Thank you very much, Dr. Osama. Outstanding. I'm in love with your talk, and I have like a couple of questions, but I don't know if Rola want me to ask at the end or right now.
Thank you very much.
Let's have a break now, and the questions are allowed during the break time. If you please, Doctor, you can go ahead.
Yeah, so for my first question, what do you think about the general awareness? What do you think about, no, I am being like very unrealistic here. What do you think about putting some taxes on unplanned pregnancy or giving incentives for planned pregnancy as a state regulation, including, for example, giving some discount for insurance? And
Yes,
because the plan mean less complication, and the insurance company would love that.
exactly. This is a good option. And definitely, this will reduce the burden on the healthcare service even. When you get a healthy woman in pregnancy, her management during antenatal, postnatal will be less harmful effect on the health service. So definitely incentives promote women to have the preconceptional care, and this incentive will be much, much cheaper than the damage or the expenses can be on the burden of the health service.
So my second question, or is a follow-up question, why we don't give
Yes.
talk to insurance company, like communicate with insurance companies and give this type of talk, and let's, do some, brochures or put it part of the policy or something like that.
Actually, in Al-Qasimi Hospital, we start to do this process. We have like several healthcare professional and from GP and specialists doing general population awareness video and brochures and sent to insurance company as well. This to especially when the patient come to the clinic and the waiting area doing nothing, they can listen, can read, and this definitely will impact on themselves and their family as well.
Okay. My other question is, thank you. My other question is, what about the medications in the pregnancy and for lactations and their effect on the reproduction and in pregnancy and lactation? Do you think this decision is an obstetrician decision or a neonatology decision, or you think should be combined? Because, in addition, our personal judgment call, we have also some kind of specialty discrepancy when we decide about different way of looking at things and treating patients.
I think we have to talk same language. We are in the same boat. Obstetrician, neonatologist, pediatrician, and general practitioner as well. So we need to talk the same language, not to confuse the patient. So definitely we have to have a reference for all medication which is safe or contraindicated during pregnancy and lactation. And there is definitely good textbook around with us. And we usually go back to it and read if it's safe or not, what is the implication. As I said, the FDA now moves her responsibility to the healthcare profession to decide if this medication is safe or not. In the meantime, we should have a multidisciplinary meeting between us and our colleague in pediatrics and the neonatology unit, and then we can reach to the good decision about which to give or not.
Okay, so you think that having like a committee in a local institute or like a steering committee in like a governing body or health governing body is a good way to start?
Yes, of course. We have the meeting definitely. If we work in a hospital like Al-Qasimi, it is women and children. So we have the two teams always work together for looking after pregnant women and children and newborn.
Thank you very much. Dr. Ahmed, you have a question, you can go.
Thank you so much, Dr. Yahya, for the opportunity. Really happy to hear from you, Dr. Osama. Actually, I have two comments or suggestions regarding the questions Dr. Yahya asked.
Yes.
So regarding the opportunity for the preconceptional awareness, actually, there is a sort of rule in the UAE that before the marriage, because here you know that the marriage has to have a certificate marriage, and there is a sort of pre-marriage let us say blood test. Actually, they are asking for sort of blood testing in the family physician setup to do this, to do those blood tests, actually mainly for thalassemia, they are doing it. So this is a conditional before the marriage. Actually, this opportunity, it's really, 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 really good, especially that it is conditioned for the marriage. So like if there is a family history, a major family history of, let's say, of for the consanguineous marriage, if there is a family history of congenital diseases, of syndromes, so there's a lot of things to work here. If the mother is she's having some disease, so I feel this is the opportunity here that because it's by rule, by law, they have to do these tests before the marriage. So I think this is a good opportunity here. One thing more.
It is actually, definitely, yes.
Yeah.
Yes, go ahead.
Second point, regarding the question Dr. Yahya mentioned regarding the medication. Actually, in the health informatics now we are using Vareed. As we are doing the allergy check for each and every patient in all the setup, I think it's important for any medication we are asking to give. It can be actually built up in the system in a way that if the mother is pregnant or lactating, it should alarm. It should alarm. So in a way that it can provide a lot of help to the health care providers wherever they are, whenever they want, without even that headache that I need to search, I need to make sure. It is in the health info, it is in the system. And in a way, just to create it in a way that it will pop up that, yeah, if the lady is pregnant or if she's lactating and you are going to give any medicine, if it is contraindicated or there is a problem with it, it will alarm. I feel this is a good suggestion if we work it up across the whole ministry.
Yes, I agree with you completely. This is a very good option. We should work on it. And actually, this is a preconceptional care, so even the medication can alert you in the system, even without the patient is pregnant currently, that if she's planning for pregnancy, please, if you take this medication, avoid it or stop it. We can replace it with a safer one for you and your baby as well. Thank you.
Thank you so much.
Well, Ahmed, I agree with you, and I love this opportunity to speak with Dr. Osama because Al-Qasimi, like any other institute I worked in my life, which are many, I worked in 5 countries, there is almost always dissociation between obstetricians and neonatologists. Now, this dissociation has a percentage, depending when you work. Some of the organization, you have 50%, some others have only 10%. Some they have like more than 90%. And I was craving for some connection between neonatology and obstetrics wherever I go, including Al-Qasimi and in my new institute, that we need to talk to each other, we need to meet, we need to discuss, and we need to make committees. Fetal-maternal committees now only run by obstetrician, which I don't think that should be appropriate, because a percentage of it should be for neonatologists, and a percentage of it should be a pediatric surgeon, neurologist, cardiologist. That joint decision would be first better for the outcome, and second would be less accountability on the surgeon. And other committees are perinatal committee, for example. Other committees, preconceptional care committee. So these type of, or simply giving presentation, talking to each other, meeting with each other. For example, difficult case outcome. Because as you know, obstetric is like the matrix, and we are the filling. So whatever the foundation they give us, we have to decorate their foundation. So the foundation are the most important. And the more we talk, the more we chat, the more we present difficult, for example, difficult cases or perinatal meeting or maternal and fetal death. These are, I think, very important too. And when Rula told me that Dr. Osama will be present, I love the idea, and I know many things will come up. I don't know what Dr. Osama can say.
Yes, yes, definitely. We are now in the era of multidisciplinary work. It is evidence-based medicine. You can't work alone. You are not the only hero in the field. We're working together, make meetings, discuss difficult cases. We have to follow the evidence-based medicine all over the world, and this is mandatory everywhere. So definitely joint committees in various way of great help to the outcome.
Thank you very much, Dr. Osama.
Thank you.
Rula, when we will start?
Another 5 minutes for Dr. Osama to break, then we will start the second session.
Yes,
Okay.
just
Sounds
5
good.
minutes, we'll come back again. Thank you.
Sounds
Thank you,
very
Dr.
good.
Osama.
Thank you
Thank
very
you.
much. Thank you. Whenever you are ready, Dr. Osama. You need to stop sharing, then open your new talk, then share, then do show.
So I'm gonna stop sharing from the green button as well.
Yes, share screen, Doctor. The green one.
To stop the sharing.
First, stop the sharing, open your second session, but then again share screen.
There is no button for stop sharing. Is it any button or just to close it down and that's it? Where to stop sharing? Who can share only host? No.
You stopped it already.
Already stopped it? Okay.
Oh, okay. So go and open your next presentation and do sharing again.
Okay. Okay, just 1 second. Right, so presentation is open now. Share screen. Yes.
Great.
Can you see it now?
Yeah, yeah.
Right, tell me when you are ready to start.
Dr. Aurora?
هلا دكتور يحيى تفضل.
Yeah, can we start?
Yes, please. Please, Dr. Osama, welcome.
Okay, so after a little break, we're gonna talk about a different topic. It is the maternal adaptation in pregnancy. As we have finished the preconceptional care management, now the patient come to you pregnant. So as a healthcare professional, you need to know the changes happen in pregnancy in different stages. To be aware if this a pathological condition or the normal change to happen. Some women will come to you asking a few questions. I'm just so worried about this and this and this. If it's normal physiological change, you have to reassure her. And you have to know what is pathological from what's physiological changes. So normal pregnancy is characterized by profound changes in almost every organ system to accommodate demands of the fetus. Thus, pregnancy results in both structural and functional changes in various parts of the pregnant woman. Some of these changes influence normal biochemical value, while others may mimic symptoms of medical disease. It's important to differentiate between normal physiological change and disease pathology. These changes usually resolve after pregnancy with or without any minimal residual effect. It's important to understand the normal physiological changes occurring in pregnancy, as this will help differentiate from adaptations that are abnormal. And this review highlights the importance of these changes. So if we start with these changes, definitely we start with the genital organ changes, including vulva, vagina, uterus, and cervix. In the vulva, it become more edematous, more vascular, and some varicosity may appear, especially in multipra. This is quite normal. Labia minora get more pigmented and hypertrophy. In the vagina, it's the same. Increased blood flow, increased hypertrophy, more vascular, and the secretion will be more copious and thin and curly white. We have to know that the pH become more acidic, 3.5 to 6, which is a protective mechanism. What about the uterus? The uterus actually undergoes significant changes in pregnancy. Starting from the weight in early pregnancy or non-pregnant is 50 grams. At the end of the pregnancy is about 1 kilogram. The volume inside the uterus very little, 10 milliliter in gynae to 5 liter in full-term pregnancy. The shape actually changes from pyriform to globular. The fundal height of the uterus can be measured abdominally. In non-pregnant, you can't feel, in the first 3 months of the pregnancy, you can't feel the uterine fundus start to become abdominal organ after 12 weeks. At this stage, you start to feel the fundal height. And this fundal height goes by time from the symphysis pubis to the fundus height by centimeter. And usually 1 centimeter equal to 1 week of gestational age from 22 weeks of the pregnancy. So when the uterus at the level of umbilicus, you can measure anything above it in centimeter means weeks of pregnancy. What about the wall of the uterus itself? It undergo hyperplasia due to the effect of hormones of pregnancy, estrogen, progesterone. The muscle is stretched over the uterus as to accommodate the size of the baby is growing. The muscle of the uterus has a characteristic arrangement. There are 3 layers, outer, middle, and inner. The outer is longitudinal, the middle is scanty and thinner, and the most important layer in the uterus is the middle layer, which is the thickest, strongest layer. It is arranged in a special arrangement or manner. It's called crisscross fashion, which the blood vessel run in between this crisscross pattern. A position of the two double curved muscle fiber gives a figure of 8, which is called living ligature. This is the most important part for obstetrician during labor. After the delivery of the placenta, uterus to contract, stop the bleeding, reduce the postpartum hemorrhage by the presence of this strong middle layer muscle to contract. Contractility of the uterus starts from early pregnancy. Women sometimes come to early pregnancy complaining of mild cramps. However, it was not recognized till 1872 by Braxton Hicks, who found this pain is due to non-rhythmic spasmodic, painless, or mild painful contraction with no effect on the cervix. And the pressure inside the uterus doesn't go more beyond 25 millimeter mercury. When the pregnancy continues and the patient goes in labor, the contraction changes from non-rhythmic to rhythmic, more stronger, more painful. It happens 3 every 10 minutes. With intensity higher than the Braxton Hicks. It is going to be 70 to 100 millimeter mercury, and definitely this will cause cervical changes to be in active labor. What about the vascular system to the uterus? Definitely uterine artery diameter double, and interestingly, from 20 weeks onward, the blood flow to the uterus changed from 50 ml per minute to more than half a liter per minute. It's very important precision, because if the patient starts to bleed, it will lose about half a liter per minute. She may lose her whole blood volume in 10 minutes. So this is very big, risky to pregnant women. Vasodilation is mainly due to estrogen, progesterone. Also, the vein become dilated and valvulus around the uterus, and numerous lymphatic channels open up. The cervix is part of the uterus, but it has some significant change, different. It is the hypertrophy and hyperplasia of the elastic connective tissue. On examination, by speculum examination, you will find the cervix looks bluish or purple in color. It's called Chadwick sign. And when you examine internally by manual examination, the cervix is very soft and it's called Godel sign. Before the modern obstetrics, when we don't have any ultrasound scan or any facilities, doctors usually examine the patient internally, speculum and internally, and can decide this patient is pregnant or not based on these 2 signs. Of course, secretion of the cervix will increase, causing leukorrhea of pregnancy. So you have to reassure the patient if she comes suffering from excess PV discharge. The ovary, what happened to it? An ovary is the source of the egg, with the produce the ovum. And after fertilization, the corpus luteum would remain active for 8 to 10 weeks. producing estrogen and progesterone hormone. And this part of the ovary remaining after fertilization is called corpus luteum. This will continue to be active till 10 to 12 weeks when the placenta starts to take over. That's at that time the corpus luteum degenerate and the placenta start to produce the same hormone in addition to another hormone. Of course, once ovulation happens and fertilization, the hormone of the ovaries stop developing any few follicles. Breast is part of or important organ during pregnancy. It increases in size, and pregnant patient usually start to feel some mastodenia, which is breast tenderness, especially in the first 3 months of the pregnancy. There is marked hypertrophy and proliferation of the duct and the gland under the effect of estrogen, progesterone, and human placental lactogen, which comes from the placenta. Vascularity increase, nipple become more larger, erectile, and deeply pigmented. There are some sebaceous gland will develop around the area of the breast, and it's called the Montgomery tubercle. It's about 5 to 15, and the outer zone of the area will be less marked, irregular, pigmented, and it's called secondary areola. Sometimes secretion of milk is called colostrum can be noticed if the breast is squeezed out by 12 weeks, but it is nothing to worry about. We move to the skin. What happened to the skin in pregnancy? The face may develop some pigmentation, especially around the cheek, forehead, and the eyes, called colwasma gravidarum. And the abdomen has a characteristic change in pregnancy, not in every woman, but we commonly encounter it in antenatal care, including linea nigra with a brownish black pigmentation in the midline. And stria gravidarum is slightly depressed linear mark, which varying in length and breadth found in pregnancy, as it shows in the picture on the right side. Now we are going to the body system by system, and see what is the changes. Every system has maybe a big textbook to discuss the changes. So now we just throw a quick highlight about what changes, what's the most important changes in each system. In the cardiovascular changes, for example, the gravid uterus will push the diaphragm a little bit up. This moves the heart a little bit lateral, and this may change the ECG finding. But the most important is the stroke volume increased by 30%, the heart rate increased by 15%, and if you multiply stroke volume by heart rate, it will give us a cardiac output, and the cardiac output will increase by 40 to 50%. What's decrease in pregnancy is a systemic vascular resistance. So it will reduce by 5%, and eventually the blood pressure will drop slightly. 10 millimeter mercury for the stool and 15 in the diastole. And actually the mean arterial blood pressure will drop as well, 15 millimeter mercury. So it is not the pregnancy will cause hypertension, it's actually reduce blood pressure, especially in the middle trimester. During the first trimester, blood pressure drop, and this might give the patient a feeling of nausea and fainting, especially in the first 3 months. Later pregnancy, the hypotension may occur in 10 women, especially if they lie flat. When they lie flat, supine position, unprotected, means the baby pressing on the inferior vena cava, causing supine hypotension by reducing the venous return and eventually reducing the cardiac output. What about the venous pressure? It increased in the lower lip significantly, in the extremities, especially because the blood volume increase, and the pressure of the gravid uterus on the venous system may increase the risk of varicosities in the lower limbs as well. Usually it disappears if the patient lie down or elevate her legs while sitting on a small stool. What about the blood changes? The blood volume, as we said, it's markedly increased during pregnancy, aiming to meet the metabolic demands of the uterus and placenta and fetus. It also protects the women from cable compression in supine position. Even if it is compressed slightly, it will be compensated by the increased blood volume. And it safeguards against PPH, which is postpartum hemorrhage. If the patient lost some blood during labor or cesarean section, because she already had higher blood volume, she keep maintained and compensate for the loss. Also increase the clotting factor, especially fibrinogen in pregnancy, help to stop the bleeding. But which one part of the blood volume increase? Actually, the blood volume has two components, plasma and cells, RBCs. The plasma increase up to 1.25 liter above the non-pregnant level, while the RBCs volume increase about 0.5 liter above the non-pregnant. So actually there is discrepancy between the increase, so more plasma increase there rather than RBCs, which will lead to what's called physiological anemia or hemodilution. That's why the hemoglobin in pregnant women drops slightly, especially in the mid-trimester, to 10.5. The minimum accepted in pregnancy is 10.5 gram per deciliter, but this is due to physiological anemia. So where this extra blood developed in the pregnant woman goes? Mainly to the uterine blood flow. As we said, it increased from 50 ml per minute to 500, 10 times increase of blood flow to the uterus. So this need definitely increase blood volume. The lung contribute to have more blood, is about 2.5 liters per minute, increase in blood flow to the lung. Kidney as well, increase 50%. Usually the renal blood flow is 800 ml per minute, it increased by 400, and the blood flow to the skin increase. That's why patients sometimes feel a bit warm. So when you go to metabolic changes, the total metabolism increased due to the need of growing fetus and the uterus. Basal metabolic rate increase in the extent of 30% higher than that of the average non-pregnant woman. This is quite normal adaptation in pregnancy. It's not, so don't mix it with any signs of hyperthyroidism or increase with the basal metabolic rate for a different reason. If we talk about the carbohydrate metabolism and fat and protein, the carbohydrate metabolism shows insulin secretion increase due to hyperplasia of the beta cell of Langerhans pancreas, and increased insulin will increase lipogenesis, which means fat storage. So pregnant patient will develop fat storage because increase some insulin. And average fat deposition in pregnancy at term is about 3 to 4 kilograms, and mainly in the abdominal wall, breast, hip, and thigh. In protein metabolism, there is a positive nitrogenous balance throughout pregnancy, and the fetus and placenta each will receive 0.5 kilo of the protein. So 1 kilo of protein or 1,000 grams of protein will distribute between the placenta and the mother. When we come to minerals and supplement in pregnancy, we have to mention the iron, the most important one. Iron is absorbed in ferrous form from the duodenum and jejunum and is released and transferred in the circulation as a transferrin. Only 10% of ingested iron is absorbed due to mucosal block. Whatever she takes iron, it's only 10% will be absorbed. So the question now, does every woman in pregnancy need iron? It was found that the total iron requirement in a normal woman with normal hemoglobin is 1 gram, 1,000 milligram supplement. This is to compensate for the fetal need. So any woman in pregnancy, even with normal hemoglobin, should need supplement. In absence of supplement, there will be gradual drop in hemoglobin during pregnancy. That's what we don't need. For antenatal care, we measure hemoglobin in a CBC and iron profile as well. Sometimes hemoglobin looks normal, but the iron profile shows depletion of iron storage. So this patient needs supplement to replace the loss to maintain hemoglobin during pregnancy. What about weight gain? In early weeks of pregnancy, a patient may lose some weight due to nausea and vomiting. This is expected in early pregnancy. But in subsequent months, the weight gain progressively increased till maybe the last 1 or 2 weeks will stay static. The total weight gain during course of singleton pregnancy, which may be more in multiple pregnancy, is about 11 to 13 weeks. 1 kilogram in the whole first trimester, and 4 to 6 in each second and third trimester. So the weight gain will be significantly increased after 20 weeks of gestation. So where is this 11 to 13 kilos extra weight goes? It's about 3 kilo in the fetus at term. Placenta is about half a kilo. Amniotic fluid between 800 and a liter. Uterus 1,000 grams and 1 kilo. Blood volume increase, as we said, 1.5 liter. And the extra vascular fluid volume increase is the same, 1.5 liter. Mammary gland, half kilo, and fat deposition, as we said, about 3 to 4 kilograms. So all together will add up to 11 to 13 weeks. Less than that is abnormal. Above than that is we don't like and is quite risky. This is just a summary, quick summary with the change of the fetal weight between 10 weeks, 20 weeks, 30 weeks, and full term. So the gain weight about half kilo in the first 3 months of the pregnancy, jump to 4 kilo in 20 weeks with the 5th month of the pregnancy, 8.5 kilo in the 8th month, and 12.5 kilo or 13 kilo at term. When we move to the respiratory system, again, the gravid uterus will push the diaphragm up, which has some effect on the lung. So all the lung function will have a reduction in value, especially with the residual volume. The only parameter in lung function increase during pregnancy is the tidal volume due to progressive increase in oxygen consumption and the effect of progesterone as well. So what does this tidal volume increase mean? There is hyperventilation. When women hyperventilate, it washes CO2 more, so it will be hypocapnia. I have to mention here, the respiratory rate stays the same, no change. So only the patient feel that she's breathless, but is not respiratory rate is increased, is the hyperventilation process. And it's quite good to have some hyperventilation in pregnancy as it causes mild respiratory alkalosis. The pH will go between 7.4 and 7.44. So why we need respiratory alkalosis in pregnancy? It has 2 beneficial effects. One of them, at the level of the hemoglobin, it increases affinity of the maternal hemoglobin to oxygen. But when we go to placental side, it will release, dissociate the oxygen quite easily through increase of 2 and 3 diphosphatidylglycerol enzyme in the RBCs. Also, it facilitates the transfer of CO2 from the fetus to the mother to get rid through the respiratory system by the hyperventilation. This is helpful to have some hyperventilation, but the respiratory rate will stay the same. What about the kidney? Kidney contribute to the changes in pregnancy as well. The kidney increase in size slightly by 1 centimeter. The blood flow, as we mentioned before, to the uterus increase, to the lung increase, is also increased in the kidney by 50 to 70%, maximum at 17 weeks and maintained to 34 weeks. Sometimes it stays the same or slightly decrease. So what does it mean, renal plasma flow increase? It means that it's going to be glomerular filtration rate or increase as well by 50%. So we have to expect that the kidney function test reading will be less than non-pregnant women. So urea and creatinine level value, we have to consider as normal if it is dropped below the non-pregnant state. This is quite normal. So don't compare the result in non-pregnant to pregnant. We have to have a value separate for pregnant women. The ureter slightly dilated due to progesterone effect or maybe due to the pressure of the gravid uterus on the ureter. The bladder has a characteristic symptoms. In the early 3 months, the small gravid uterus will press on the bladder because it's still pelvic organ. When it grows up, it goes away from the kidney, but later in the pregnancy, when the near term, when the fetal head comes to the pelvis, it starts to press on the bladder again. This will increase the frequency of micturition. By mentioning that the urine in pregnancy showed some mild alkalosis, secondary to the alkalosis in the blood. Alkaline urine increase the risk of urinary tract infection in pregnancy. That's why we request a urine culture in pregnancy to detect early changes or asymptomatic bacteriuria and to treat promptly. Patients sometimes complain of stress and incontinence in pregnancy, but this is temporary and disappear after labor. The gastrointestinal system shows some changes, including gum congestion, heartburn, pyrosis due to relaxation of the esophageal sphincter, and the gastric stomach, I have to mention here, the gastric empty time is not delayed in pregnancy. So it's no delay except only in the patient in labor. And this is put some risk on the anesthetist if they're gonna give her general anesthesia for emergency cesarean section. The gut will be slightly sluggish in mobility, and this may end up constipation or increased hemorrhoid during pregnancy. What about liver and gallbladder? Liver enzymes stay the same or slightly decrease, but no significant change. The only change in liver function is the alkaline phosphatase, which is double due to the addition of placental origin of heat-resistant alkaline phosphatase. Serum albumin slightly decreased, but the total protein in the blood will stay the same due to increased blood volume. And the gallbladder shows some laxity, and this may increase the risk of gallbladder stone. Nervous system, some women suffer from memory changes during pregnancy or puerperium, maybe sleep pattern disturbance. The above factor is not of itself of significance, but it may contribute to postnatal blues or depression or psychosis, especially in susceptible individuals. So not everyone will develop, but this is additional factor during pregnancy with memory change and sleep pattern disturbance to have a postnatal blues. Of course, the occurrence of the postnatal depression blues is high in patients with previous history of the same condition. When we talk about hormone in pregnancy, we have to mention the placental hormones, which is endocrine organ producing estrogen, progesterone, as well as several other hormones like human chorionic gonadotropin and human placental lactogen. All these hormones has its own effect on the maternal body, including like human placental lactogen, increase the growth of the breast. Estrogen, progesterone, as we mentioned, have lots of effect on the vasculature, uterine wall muscle, and the other organ of the body. Thyroid gland in pregnancy has a special criteria. It's increase in size, and some women will develop large thyroid gland or goiter in pregnancy due to hyperplasia of the glandular tissue and increased vascularity, and also due to increased uptake of iodine in pregnancy due to increase in the thyroid binding globulin. This will take more iodine. Pregnancy can give impression of hyperthyroidism in a way of increased metabolic rate, increased pulse rate, but the thyroid function should basically stay normal with a TSH to be kept below 2.5 millionit per liter. Placental HCG share alpha subunit of thyroid releasing hormone. So thyroid releasing hormone, thyrotropin releasing hormone from the hypothalamus has a similar or alpha subunit. Each hormone of these has alpha and beta subunit. So the alpha subunit is similar in various pituitary and hormones, and sometimes they give its effect. So HCG alpha unit similar to thyrotropin releasing hormone, and this might stimulate the thyroid gland, especially in twins and trophoblastic disease, trophoblastic like molar pregnancy, where the PHG is significantly higher compared to normal singleton pregnancy. The basal metabolic rate increase mainly because of increased consumption by the fetus and the maternal heart and lung. The pituitary hormone, the secreting prolactin, ACTH, TSH, and melanocyte stimulating hormone, all these increase FSH and LH, which is the follicular stimulating hormone, and luteinizing hormone, is greatly inhibited by the placental progesterone estrogen. The effect of prolactin secretion are suppressed during pregnancy due to estrogen. So the prolactin increase from the anterior pituitary try to prepare the breast glands to produce milk, but it is not expressed till after delivery. When the estrogen hormone drop, then the expression of the milk start by the absence of estrogen hormone and the effect of oxytocin, which comes from the posterior pituitary gland. So the oxytocin is reduced and produced in low frequency pulse during pregnancy. But once the pregnancy ends, by delivery, the pulse increase and the frequency of the oxytocin increase, trying to express the milk from the milk duct and bring the glands outside for lactation. Thank you very much.
Thank you very much, Dr. Osama. It was very, very interesting. And I'm more happy than presentation is that we're meeting you as a representation of obstetric, and want to show our fellows how important to collaborate between obstetric and pediatrician, especially neonatologist.
Yes.
My question to you, what do you think about somewhere during these antenatal visits that the couple should see a neonatologist or a pediatrician, or at least give them a piece of paper containing some information about what exactly happened when the baby is okay, how long you're gonna stay, and if the baby is sick, what will happen, general broad type of information.
This is part of the developed country antenatal care. The antenatal care is not only for obstetrician, it's only for pediatrician neonatologists as well. It is for midwife, for doctor, for neonatology, all to share the antenatal journey of the pregnant woman. So not only visiting the clinic, the patient need to know where she's gonna have her baby, which room she's gonna stay in, which theater room we go if she go for cesarean section, who is gonna receive her baby, what steps to be done for her baby. This all in the prenatal care management in a well-established maternity unit. So definitely they should see the neonatologist during their journey in the hospital.
We, in Manitoba, we were doing some kind of what we call it, one of the antenatal visit they do,
Yes.
or where we were doing a tour.
Yes,
An
antenatal tour. Yes.
We take the baby, there is 3 or 4 times a week done by one of the educational nurses. They took the group of parents, they bring them, they show them the labor, they show them the NICU and so on. And that will
Yes.
help increasing compliance and also increasing increasing compliance and also decreasing complaints.
Yes, of course. The patient is not anxious, not stressed. She doesn't know what she's gonna meet, who's gonna meet, where is the place to deliver. So all this is a big hassle to, especially if a primary gravida in her first pregnancy doesn't know anything about the hospital. So antenatal tour is essential, of course, for patient satisfaction.
And on top of that, they were doing some financial advices, like what exactly the cost, if it's insured or not insured, something like that. So parents are ready for not like things comes like that, especially for those who have no insurance and they need to pay cash. Paying cash is even difficult for us, and we are considered good earners. How about people who are like skilled workers?
It's very important because some public, in the public, there is a rumor saying if your patient come in labor, this is an emergency, it is free of charge. But it is not. It has to be emphasized in her antenatal care that this is pregnancy, it is 9 months journey, it is not suddenly happen over the night. So she has to be prepared, even coming in labor at any time. It is not an emergency and be dealt as a normal clinical entity.
Yeah, and I don't know what you think about. I don't think this is like a job of a healthcare provider. It should be like a financial specialist, making like once a week a gathering about, the cost, and then and give them advice on an emergency or an ICU, days of admissions, C-section or normal delivery, instrumental, what happens if a complication happens. Something like that would be great.
Yes, definitely, because the tour includes few steps, few stations. One of the stations to visit is the financial department.
Yes.
They need to discuss any query about the finance, about the expenses during this hospital tour.
And that was actually what one of my thinking when I suggested to do a perinatal committee. And of course, the response was, we were already having, but stopped. Okay, well, if it stopped, let's reactivate.
Definitely,
but again,
yes.
yeah, things
Very
didn't
important.
move the way that I was hoping.
Yes.
Now, I don't know, Dr. Arula, if anybody has a question. It was a great talk, and I think the meeting was better than the talk itself. And I don't know why people are complaining they cannot register. I don't know why. I mean, very clear. You can click and go in. So I don't know what happened, Rula. Many people.
I have received 2 requests on my WhatsApp to admit them into the room, but I have already admitted them earlier, and I have nobody waiting in the lobby. I don't know.
No, they are sending me they sending me pictures saying that once they want to log in, they cannot go in. I don't know why.
I have not restricted anything from my side, Doctor.
I don't know. I don't know what happened today.
Dr. Osama, I have a question.
Yeah, go ahead.
Yes.
Okay,
Yes.
what is the indication to give packed RBCs, and what is the indication to give iron IV for a pregnant lady?
Yeah, very good question. We meet every day.
Yeah.
Of course, blood transfusion has its own drawback. Unless it is really, really indicated, we prefer to give iron. But sometimes women forces us to give blood transfusion, like what? Unbooked patient coming to us in the 3rd trimester, 35 weeks, 36 weeks. And iron infusion will take about 2 to 3 weeks to improve the iron level. So she will deliver before that. So you have to give blood to improve her general condition as a part of improving pre-delivery care to get a good outcome. So sometimes we have to give a blood transfusion, or if early in pregnancy hemoglobin is very low, make her symptomatic. She cannot cope with very anemia, very low hemoglobin, like anemia, hemoglobin 5 or 6. I don't think it is fair to give her iron, leave her to suffer for another 2 to 3 weeks before her hemoglobin improves. So this is an indication for blood transfusion. So either very low hemoglobin or come to us very late in pregnancy and no other option to improve her hemoglobin level.
Yeah, thank you. If we have no more questions, Dr. Yahya, can we close the session? Dr. Osama, thank you very much for today's lecture.
Thank you very much.
We will be also with you.
I just put a picture for Dr. Osama, so I can put it the thumbnail on the registration, on the YouTube registration.
Sorry, say it again. What do you want to put?
I want your personal photo or the photo, because when
okay,
you on YouTube,
okay.
It will be a picture.
Yes.
So I don't want the YouTube to select any picture. If you don't mind, send me a picture and then I will.
Sure, inshallah.
Because if there is no picture, the YouTube will select any.
Okay.
Okay. And Dr. Osama, I guess the next session will be maternal conditions affecting fetal outcome, if I'm not wrong.
It's not today, because this is
Not
the
today,
2 books today.
Next week.
Not next week, end of the month, because there are 2 other consultants presenting in the week, next week and week after, and then I'll come at the end of the month.
Okay, that's great. Thank you very much.
They presenting to us, Doctor, or not?
Sorry?
They're presenting it to us or somewhere else?
In our
yes, to you. Yes,
Okay. I just need to be prepared and announce it. And this time I need to announce it very well and make sure that these links are working. I don't know what happened today.
It is an Ops and Gynae month today, so for you.
We are honored. I'm very happy.
Yeah.
Thank you very much for tonight, and have a good night for everyone.
I always say, before we go, we obstetrics call us for many times. 39 times are false alarm and 1 time is the true alarm. But whenever we go there and they feel safe, it should be okay. So we are there usually to make them safe. And I mean, when they safe, I mean the outcome of the baby. Thank you very much. I really appreciate
Thank you very much. Thank you.
Thanks a lot. Thank you.
Have a good
Thank
night.
you.
Thanks.
Thank you
Bye.
very much, Dr. Osama.
Thank you.